couple minutes late, so apologies there. I'm going to go ahead and get us started. Welcome to our July Lunch and Learn. I am Amanda Lakin, the Director of Communications for the Nevada Housing Coalition, and I have just a few announcements. As you have hopefully all heard, we have our upcoming 2025 Nevada Housing Conference taking place in October 15th and 16th in Las Vegas this year at Circa Resort and Casino. Our registration is open for this event, and prices will be going up in just about 3 weeks. So if you are planning to attend, we would encourage you to register soon, as prices will be going up about $50 on August 18th. And we are also accepting sponsorships. As hopefully you also know, our sponsors are one of the main reasons that we are able to put on such a great event every year. Great venue, delicious food, and fun networking opportunities. We have a variety of benefits and levels available. So if you're interested in sponsoring, please reach out to me. This is a great opportunity for you to get your name and organization in front of around 350 to 400 affordable housing stakeholders. And also, just to save the date for our members, the day before our conference on Tuesday, October 14th, we are going to be having our annual member meeting and mixer. This is also going to be at Circa Resort and Casino from 6 to 8 p.m. if you attended last year. This is just going to be very similar, a great way to network with other members, and we're working on confirming a really fun speaker for the event as well. So keep an eye out on your emails. Registration is going to be happening for that soon. And I am going to kick it over to our moderator for today. Valerie Lovano is joining us with Anthem. Welcome, Valerie.
Thanks so much, Amanda. Hopefully everyone can hear me okay. I am super happy to be here today moderating this conversation about the intersection of housing and healthcare. A lot of work and a lot of important work is being done in this area by a lot of folks on this call, and I'm just super happy to be a part of helping to facilitate the discussion. A little bit about me. I know my background has the Golden Gate Bridge. I'm not from San Francisco. I live in Reno, Nevada. I'm actually a social worker by training. I've been a social worker for about 25 years. I live in a rural part, actually, of northern Nevada. So very proud of that. All of my kids have been born here. I have 5 wonderful kids that are adult children that are off doing their own amazing things, some following in my footsteps, maybe a bit unwillingly, but nonetheless into public health work. Currently serve as the Whole Health and Equity Director for Anthem Medicaid. And what that means is I partner with internal and external community-based organizations, governmental entities, a variety of groups to improve health outcomes, population health-wise, as well as address health disparities. And an important part of that work is to address health-related social needs that keep people from reaching optimal health and actually increase the likelihood of health disparities. So I do a lot of work with the amazing Emily Paulson, who I know many of you on this call love and work with on a regular basis. And I am stepping into her very big shoes today to moderate this conversation. I know she would be happy for me to share some of the amazing work that she has helped create and that Anthem has championed around housing and healthcare. Emily, in a very, very short time at Anthem, has helped the organization really grow and promote several housing options that are available to our members and that support the community at large. So Emily, with cooperation from Anthem and support of Anthem, has actually created a housing portfolio that provides a continuum of services and includes basically a dozen interventions to help members, all the way from eviction prevention to permanent supportive housing. And she is also instrumental, along with a couple of other of us, in leading the charge to implement what are called in lieu of services and housing supports that will be billable through Medicaid very, very shortly. And hopefully we'll have an opportunity to discuss some of the impact of that opportunity on the programs that we all kind of collectively manage and the services that we provide. So enough about me. We have three amazing presenters today who are going to share their work in this space and will be available to answer questions at the end. So if you do have questions, feel free to put them in the chat. Those that we aren't able to get to, we will make sure to get answers back as needed. So without further ado, I'd love to introduce you to our first presenter, Andrew Moran of West Care Foundation. I'll let him give a better description of himself and his work. Thank you, Andrew.
Well, thank you so much, Valerie. I appreciate everything that you do, and I'm really excited to be a part of this. I love the Nevada Housing Coalition, been part of them since the beginning 5 years ago, and watched their journey, and what they've done for Nevada is just nothing short of amazing. The funding that they brought in for the housing space, and I'm just really proud to be a part of it. I'll start off here with what I do. I'm the development director at West Care Foundation. This is a nonprofit that has been in the Nevada community for 50 years now, and we are in 17 different states and 4 US territories we've grown. Our mission is to empower everyone we come in contact with to engage in a process of healing, growth, and change, benefiting themselves, their families, coworkers, and communities. We do this through our efforts towards uplifting the human spirit by consistently improving and strengthening everything that we do. I'd like to go on and talk a little bit about our team in the next slide. I want to first talk about Leo Margadishian. He brings a wealth of knowledge to our team. We have a wide range of team members, and we all bring so much expertise, and we love to share that. He's our regional vice president, and he plays a crucial role in overseeing the operations, ensuring that all of our services align with our organizational goals. I'm originally from Las Vegas, born and raised. I came to West Care 5 years ago. I love what they do. I love their vision of helping people. And so I'm now the development director there, and I basically put the fun in fundraising. I go around to all the private and public partnerships and try to raise funds wherever they are for different supportive services. And I'll be touching on one of them, which will be our Women and Children's Village that we're currently building. Lastly, that brings us to Scott Falkenberry. He's our Chief Development Officer, and he brings 30 years of experience to the team. So we have a lot of good people working towards a mission, and that'll bring us into our presentation. So next slide. I want to talk a little bit about the interplay between housing and health. Basically, stable housing is the foundational determinant of health. Lack of stable housing leads to increased health risks and costs. Vulnerable populations face the most significant challenges. So as we explore the critical connection between these two and the cross-section, I want to recognize that stable housing is not just a roof over one's head. It's basically the fundamental determinant of overall well-being. Research consistently shows that individuals who are homeless or experiencing some kind of like unstable housing, they face a myriad of health challenges, including higher rates of chronic diseases, mental health issues, and substance use disorders. Many of our audience today, you may not realize that just how severe this crisis is. For instance, individuals without stable housing often delay seeking medical care due to fear of high costs or the inability to access transportation. This delay can lead to emergency room visits, which are significantly more expensive than preventative care. Moreover, the stress and uncertainty associated with housing instability can exacerbate the mental health issues, creating a cycle that is difficult to break. A study from the National Coalition for Homeless just found that 25% to 30% of all the homeless population suffer from a severe mental illness, and that's severe. And many of these individuals lack access to the necessary supportive services that could help them regain their footing and get them their ultimate goal, which would be housing, permanent housing. So understanding this interplay between the housing and the health, it's really essential as we advocate for comprehensive supportive services. By addressing housing instability, we can improve health outcomes and reduce the overall cost to overall healthcare system. So now I'm going to talk a little bit with our next slide about our village. This is one of our projects that we're doing right now. We're really excited about it. The Housing Coalition's been a part of it, as well as we've gotten funding from the city, funding from federal, from Congressman Horsford, and funding from the private sector. So we've been going through the state, everywhere we can find funding to fund this place that is really, really needed. So I'll give you a little bit of an introduction of it. It's basically a village for women and children, and it's going to empower individuals to heal and grow and change their lives as those of their family members and their communities. In Nevada, we operate, right now, we have many facilities. We have a 51-bed community triage center. We also have a 130-bed women and children's campus, and also a lot of outpatient services across Nevada. We also have a men's facility that is up in Mount Charleston that is beautiful. It's 15 acres. It's in the middle of the BLM, in the forest, gets you out of the heat. It's a wonderful program for our men. Ultimate goal would to be treat the men, treat the women and the children, and then bring them together in whatever form that may be. It's very important. Many of the women recovering from the substance use disorders, they struggle with economic self-sufficiency. They have, bad health after detoxification. So we found that transitional housing, or they call it sober living, is the next step, and it's crucial for these women and their children, enabling them to maintain recovery in a stable environment. Supportive services must be gender specific, trauma informed, and highly structured to effectively assist pregnant and parenting women. So we have launched this initiative. It's been a dream for about 10 years. It would be the first of its kind where the women can keep their children as they continue to get the supportive services that they need to truly acclimate back into society. This is going to be a $22 million campaign to construct the village. We're happy and proud to say that we raised half of the funding, and we knew that the needed to be done now, not in 2027 or 2028. So we're proud to say that we'll be finished with phase 1, which will be 23 apartments and 2 multi-purpose rooms by November 1st, which is very exciting. This expansion that we're going to have will triple the capacity to serve women in recovery, allowing us to support both WestCare clients and those from other locations. We're proud to say that we will be able to have this ribbon cutting and have these women move in very soon and be able to get those services to ultimately reach the goal of having their own permanent housing with those wraparound services involved. So the village will be 84 cottages, multi-purpose rooms, community gardens, and children play areas. There'll be a learning center, which will be focused on development needs for children. There'll be supportive services, which will include group counseling, recovering coaching, employment readiness, and case management, ensuring comprehensive care for all of our residents. And collaboration and community partnership is key. Getting in touch with the housing authority and putting them in position with other programs like Unshakable, things like that is what really makes our community thrive. Some of the other things at the facility will have their own individual apartments where a caseworker or a therapist could come in right into their own couch and perform some services, help them out, point them in the right direction, find them that housing. All of those things we will be able to provide there with the 2 multi-purpose rooms so that they can get classes and other things that are very important. And we're also hoping to help the children at the same time. We want them to realize that they weren't in an institution. They weren't there for 3 years in an institution. We want them to think that they were at somewhere like a Boys and Girls Club camp or somewhere where they learned something. And this is what helped their families and made their families basically succeed. So the village really represents a significant step forward in our commitment to uplifting the human spirit and creating a lasting change for these women. And then I'll go on to our next slide as we're moving through. And this is basically kind of an overview of the facilities and the services, as well as kind of talking about different programs that are offered there. And then you can also see our footprint in slide 5. It has the community gardens and the 84 units And as you can see, there's some really happy families there. I don't want to take too much time, but there's so many success stories going through our current facility right now, that, mothers that just had 2 twin babies. We've had 18 drug-free babies born just this year at our facility, where the mothers can keep their kids there for 30 days while they receive treatment. And then we hope they transition to the property that's right behind them, and then they can continue and live up there till almost 2 years rent-free as they acclimate back into society. And then that'll move us on to our next slide. And this is basically, I wanted to talk a little bit about the ROI, or rate of investment. Basically, as we delve into the return on investment, it's crucial to understand how housing and treatment are interlinked and why investing in both is essential for our community. Connecting the housing and treatment, it's a roof over one's head, but it's the foundational element for recovery, especially for people that have received trauma. So we see that taxpayers, basically, it's going to save them between $2 and $8. And WestCare has researched this for every dollar invested. This statistic highlights the efficiency and effectiveness of our approach. Substance abuse is one of the top health challenges in the US, costing society approximately $510 billion annually. And this encompasses crime-related expenses, lost productivity, and healthcare costs. By investing in treatment and prevention and housing, we're not just addressing immediate needs, we're preventing future costs by reducing emergency room visits, hospitalizations, and instances of incarceration. I want to just give a couple more little statistics. For instance, by preventing opioid addiction and relating crises like overdose deaths and fatal accidents, we create safer neighborhoods and healthier families, which ultimately leads to a more productive workforce. That's why access to funding like the Attorney General and Governor Lombardo's secured from the opioid crisis is so important to housing and treatment. Over $720 million is coming to Nevada to be used for good. So I hope that the data presented will show you that implementing the village at the Women and Children's Campus is very important for our society. And by investing in comprehensive housing and treatment solutions, we can break the cycle of poverty and create a lasting change for all of our families. Now I'm going to just go on to our next slide as we were wrapping up here a little. This is just basically the cost in comparison, treatment versus incarceration. And you guys can look a little bit more of these slides if you want to download. And my email is there if you ever want to talk a little bit more about this. But most importantly, as we explore this slide on financial implications of treatment versus incarceration, I'd like to say that 95% of the people that are locked up right now in prison, they'll once again be integrated back into society and will live in our communities. Don't we want the best treatment and services for them to recover and rehabilitate? I'm all about rehabilitation, not retribution. Also, investing in treatment benefits individuals and offers substantial savings for our community. Lastly, I'm just going to touch on a quick little statistics here. Incarcerations in Nevada can cost $62,000 per individual, making it 5 times more expensive than treatment. The Nevada Department of Corrections spent $282 million to incarcerate 13,000 inmates, placing Nevada as the 12th highest state for incarceration rates. So basically, treatment programs yield a $1.44 return for every dollar spent. As we move on to my last slide, I just wanted to touch on a little bit about the importance of the path to permanent supportive housing, because that's what our ultimate goal is. That's what the Housing Coalition is doing. They're trying to get people in somewhere that they can hang their hat on. And today we're going to explore how that transitional housing sets the foundation for permanent supportive housing and financial security. Supportive services play a vital role in helping individuals transition successfully from treatment to stable housing. All of the services I talked about, this will regain their independence so that they can thrive. Transitional housing as a stepping stone. It's a very crucial bridge. After 50 years of being in this business, this is going to be our first of our kind. So we're hoping to multiply it and be the flagship, because we saw that this was this one missing piece to get them to that ultimate goal of permanent supportive housing. So that's about all I have. I just wanted to end it on my last slide, which is going to be our photos of the groundbreaking of the Women and Children, as well as photos of the work being done and the completion of our first phase. You can see the following picture is of our groundbreaking event on 2/22/24, where First Lady Donna Lombardo spoke about the amazing project. The Housing Coalition was there in Fort Force, Amanda Laking, Christine Hess. I mean, I could go on, Maurice, but the Housing Coalition, Mayor Goodman, everybody was there because West Care has touched someone's life along the way, and we want to just keep the ball rolling. As we celebrated this monumental day, and we're hoping to have the whole entire thing finished by next spring, next summer, which will be the complete 84 units. As I close, I will take any questions after the others speak. And I'm always available to visit, or if anyone wants to come out for a tour. By supporting these families in this way and addressing their issues, we're not only promoting a healthy family dynamic, we're basically showing positive parenting practices, and the ripple effect will continue through the generations. So thank you everyone for letting me share.
Thank you so much, Andrew, and congratulations on the amazing work you're doing in the community. I especially loved the logo in the sand. I thought that was great touch to whoever did that. That was amazing work. And I appreciate you sharing the ROI. I think that's always the challenge for us, right? It's so much easier for folks to pay for stuff after the fact when they have no choice, rather than invest it up front. But we know it's much less expensive on the front end than it is on the back end. So I appreciate you sharing that information, and curious, maybe we'll have time for it at the end to talk about ways we can partner on data collection to support ROI. So thank you again. Look forward to chatting during the Q&A later. For now, I'd like to turn it over to our next presenter, Nick Fritz from Intermountain Health. Take it away, Nick.
Thanks so much, Valerie. And Andrew, thanks for the great presentation. You guys are doing incredible work, and amen on the link between housing and health. Hi all, my name is Nick Fritz. I lead place-based investing for Intermountain Health. I'm based in Salt Lake City, but we do some work in Nevada, so I'm going to share a little bit about that today. I want to start by just spending 2 minutes talking about Intermountain Health, just in case anybody might not know who we are. We are pretty new in the Nevada market, relatively speaking. And then talk a little bit about the link between housing and health in our experience as a health system, and then try to share some thoughts on kind of what we're doing about it. And I'm going to try and get all that done in the next 10 minutes. Can you go to the next slide? Thank you. Perfect. So just a couple quick stats on Intermountain Health. We're a regional health system. We're based in Salt Lake City. We work in 6 states, including Nevada. We are an integrated health system, so that means we have an insurer as part of our overall business. That insurer's name is Select Health. And we operate 33 hospitals and a little more than 400 clinics, I think now, 65 of which are in Nevada, in Southern Nevada, in Clark and Nye counties, I think. You can go on to the next one. Also, you may have seen this in the news. I think it's worth calling out here. We announced somewhat recently in the last month or so and did a groundbreaking for Nevada's first standalone children's hospital. It'll be Intermountain Children's Health. The construction properly begins, I think, in next year in 2026. And the plan is to see the first patient in 2030. So we're really excited to be deepening our footprint in Nevada. Can go on to the next one. So I wanted to take a minute and just sort of put a finer point, Andrew, on maybe some of the things that you said about the link between housing and health. So a couple of years ago, we partnered with our insurer to ask this question, right? For those patients and members who we are seeing, who we know are housing unstable, what's their utilization of the health system look like, right? Like how do they show up to us? How do we interact with them? And importantly, are there ways that we can be serving them better to improve their health outcomes? So as a part of this sort of analysis, we asked a couple of different questions. One of those questions was, how often is this population who is housing unstable, which for the purpose of this study meant that they either listed a homeless shelter as their address, they in some other way identified to a provider that they saw at some point that they didn't have a good housing situation to go back to. So they were sort of flagged as having a housing need. So how are those that are housing unstable? What does their utilization look like in terms of preventable utilization, right? In other words, how often are they using the ER or inpatient services for things that they don't need to necessarily use the ER inpatient services for? What we found is and this is a Select Health Medicaid population in one county in Utah, right? So really small sort of set here. For members with housing instability, they had a rate of one or more preventable. They had 43% of them, had one or more preventable visit in a year, compared to their Select Health Medicaid peers in the same county who didn't have sort of this observed housing instability. They were having 13% of that population had one or more preventable visit in a year. So this was sort of the first question we asked, and this sort of made us hungry for more, right? We're like, okay, that's really a big difference, statistically significant for sure. What else do we know? Amanda, could you go to the next slide? Thank you. So we said, okay, what is, how are they showing up to us? What do they need treatment for? I suspect folks on this call will not be surprised by this. And Andrew, you alluded to this. But, we looked for this group of a few hundred people, again, in one county in Utah, who are Select Health Medicaid members. What does their sort of clinical profile look like for those who are housing unstable versus those who are not? And I won't read the whole table to you, but you can see here that middle column is those with no observed housing instability. And that third column on the right is those with observed housing instability. So, rates really significantly higher rates of having multiple chronic conditions, 24 versus 54%. Behavioral health or substance use diagnosis, 30 versus 71%. Serious mental illness, I think this is the largest single difference, 2.6% in the sort of general Medicaid population versus 24.2% in the housing unstable population. So what this told us was, this is a complicated group of folks that we probably need to surround with care management services and other things. I won't go into any more detail on the project. I'm happy to answer questions about it if it's helpful, but our insurer is launching some programs to try and help serve this population better. Valerie, really interesting to hear what Anthem is doing. And to put the final point on this slide, in terms of cost of utilization, right? We determined that for this, again, very small population, this is about a $2.5 million problem a year for the health system. And just having that number, it's the first time we had sort of done that math as a system, and that has begun, I think, to change the way that we're thinking about our role here. So what are we doing about it? Let's go on to the next one, Amanda. We're engaged in a variety of programs to try to move upstream of poor health outcomes and address some of the root causes of poor health. We recognize that even the highest quality, lowest cost care really isn't going to make, it doesn't make a population healthier. So if we are going to accomplish our mission of helping people live the healthiest lives possible, we need to get upstream of poor health outcomes and start to address some of those root causes of poor health. We call those the social drivers of health. You may know the phrase social determinants of health. People call them different things. But they are those root causes of poor health. And we have a variety of different programs that are set up to address this. Those are led by our community health group. Will Rucker is our local leader in Nevada. You all may know Will. They really are sort of the spearhead of most of our social drivers of health programs. I'm going to go into some detail about one of those, which is our place-based investing work, and that's what I lead. You can go on to the next one. So for quick definitions, what is a place-based investment? We invest in projects in the community that we see as addressing a social driver of health for a low and moderate income population across all of our states. So that includes in Nevada. The graphic on the right is kind of how we define social drivers of health. Sorry, I have some old terminology in there. Amanda, can you go to the next slide? In terms of, oh, can you go back just one? Thank you. In terms of our place-based investments, we've focused on two things: trying to address housing instability and income and employment. Okay, you can go on to the next one. So what does that mean? In simple terms, it means, we have mostly provided debt, low-cost debt, to support the construction or preservation of affordable housing units across the states that we serve. We do other things too, right? We do some economic development work. We have done a little bit of kind of green energy work, but principally, we're working in affordable housing spaces, either helping to produce units or providing, being a source of funds for, kind of non-unit producing financial instruments. So like down payment assistance, or other kind of financial products or services that may not otherwise exist. So to give a sense of sort of our scale, we have been doing this in Utah for 6 years. That's where this started. We are new in all of the other 5 states you see there, which is why it's so lopsided to Utah. But we are actively kind of seeking projects in Nevada, with some emphasis on Southern Nevada. As I mentioned, all of our physical location is in Clark and Nye County, but technically the whole state of Nevada is kind of inbounds from purely a sort of, I don't know, it's all inbounds. And we've supported over time, a few thousand units of affordable housing, a little more than 2,600, and have supported over 1,000 folks, either with down payment assistance or low-cost mortgages. I will say, the last thing I'll say is, again, our sort of principal tool is debt. We can do that at the project level. We tend to be a pretty short-term lender, so we work well in the kind of acquisition, pre-development, construction participation phase. We have participated in some LIHTC projects. So LIHTC is inbounds on the short-term side of things. And we, in terms of our borrowers, our borrowers have been nonprofit developers, for-profit developers, housing authorities, homeless services providers, substance use disorder providers. So we're pretty open in terms of who the borrower is. For us, the question is the project addressing a social driver of health, meeting a need in the community for a low and moderate income population? So I'll stop there. I realize I forgot to put my contact information in these slides. I'll put it in the chat in case anyone wants to reach out. But thank you so much for your time.
Thank you so much, Nick. That was amazing to learn about all of the investment work that you're doing as it relates to social drivers of health, and particularly housing instability. And I would just echo some of the utilization statistics that you showed. We do find reduced utilization of ER services, inpatient services, BH, behavioral health inpatient services, when folks are stably housed. If you don't have a roof over your head, it's really difficult to treat your medical needs and to address your medical needs. We also find that when folks are housed, they have supportive wraparound services that they have access to, they also get the care they need. They get their doctor's appointments. They go to the behavioral health treatment, and we have, the statistics and data from our own programs at Anthem to support that work. And we're very excited that soon those wraparound services, which are so essential to the success and enabling the medical care once folks are stably housed, will be part of ILOS services and billable for community-based entities and organizations. So really excited to partner there. And now I will stop talking. I am the moderator, not the presenter, and I will turn it over to Julia Ratty from Washoe County.
Hi, everyone. So I'm going to be the slacker on the call that did not put together slides. I apologize for that. I think that let me just do a brief introduction. So my role is in late 2023, the Washoe County Commission identified behavioral health as one of the top strategic priorities for Washoe County, the government. Primarily because what we were seeing as a county, and when you think about the counties, of course, we have responsibility for many vulnerable populations. If you think about children who are in the child welfare system or folks who are going through our justice system, which impacts, of course, DAs, public defenders, the courts, our jail, the large population that is sitting in the jail that has behavioral health challenges. But even if you think of like our public guardian, who is charged with overseeing the care of folks who are unable to care for themselves, what we were seeing over and over again is that behavioral health challenges, I should say, are driving significant growth on all of those systems. And our resources are not keeping up with that growth. And so the county decided that it was worth investing time and energy in identifying behavioral health as a top strategic priority and pursuing those efforts. I've been in my position since April of last year, so just going on about 15 months. And we're working on 3 significant initiatives. One is the development and rollout in collaboration with many, many other people across the state of a best practice crisis response system, so that we can catch individuals who are having a behavioral health crisis in the early stages and hopefully keep acuity lower, keep the crisis stabilized, and meet people with a behavioral health model as opposed to an EMS model of care. The second is the sequential intercept model. It is an effort to identify, there's so many people who are interacting with our justice systems primarily because of their behavioral health challenges. And so this is all about how do we do better intervention coming from the side of like, let's get people behavioral health care instead of having them be involved with the justice system. And again, a lot of the data that's been presented here supports why we would be doing that work. And then the third is the county actually purchased, we had a behavioral health facility in Washoe County known as West Hills close its doors. And that blew a big hole in our behavioral health continuum of care. And so the county actually purchased that building, and we are working on remodeling that building and bringing it back into the continuum, hopefully to open by late 2027 with a suite of behavioral health services for children. And so those are some of the big initiatives and the things that I'm charged with trying to move forward from a systems and policy level, obviously big things that we're trying to accomplish without a lot of new resources right now. What we are finding in all of those initiatives is that the #1 barrier to success that comes up in every assessment and every conversation and everything that we have done is housing. And that is a range of housing from emergency housing to transitional housing to affordable housing to, and when I say affordable, I mean subsidized affordable housing to supportive housing. And that lack of that continuum of housing is really interfering with us as a system and our ability to move the needle. And obviously, more importantly, the ability of individuals who are experiencing behavioral health challenges to be successful. I want to just talk quickly about, so also as part of my background, I was privileged to serve 5 years in the Nevada State Senate and to serve as the chair of the Health and Human Services community and to do some policy and advocacy work specifically around behavioral health. And so I do want to talk a little bit about the state of things in Nevada. And I appreciate the good news that Andrew and Nick brought to the table, because there are bright spots. There are definitely bright spots, but the scale of the challenge in Nevada is significant. And so let's just take a minute and talk about, I think this particular topic is the affordability of housing, or the lack of affordability in housing, causing more health challenges, or are folks' health challenges leading to their housing instability? It's a bit of a chicken and egg problem, right? And we know that the answer is yes to both. So if we just want to talk about specifically affordability, and we know, and I'm talking to a group of housing advocates, so you all know this, that the most that any one individual should be spending on their housing is about 30% of their overall budget. And we know that in Nevada, so many people are spending so much more than that. 40 to 50%, some 60% of their budget is going to housing. When that percentage of your budget goes towards housing, most folks are looking at housing, health, right? And so if you're going to, and food. And so we put people in this position of needing to choose between, am I going to be able to pay my rent or my mortgage? Am I going to be able to pay for my healthcare, or am I going to be able to pay for food? And what is the quality of the food that I'm going to be able to purchase? And so there's all kinds of data out there. I don't need to necessarily, I know you all know this, it's logical that if you are spending significantly more money than 30% of your income on your housing, and you're in the lower income tiers in our society, our less resourced friends and neighbors, it is impacting your health because you're not having access to healthy food, and you're not having access to healthcare because that is where you're needing to skimp to keep a roof over your head. So we just know that the overall lack of affordability in the state of Nevada, and really our nation at this point, is causing meaningful health challenges for individuals. Let's just talk a little bit about scale. I haven't looked at the numbers recently, but I don't think they've changed significantly. If you're extremely low income in the state of Nevada, we have about 17 or 18 units for every 100 that we need. Take that to the population of Nevada, and we're talking about tens and tens and tens of thousands of affordable housing units that would need to be built to be able to serve that extremely low income. We're talking 50% of AMI or less. Those folks are desperate for affordable housing, any affordable housing. And if we can make more progress on that particular issue, and again, wonderful wins with the $500 million that was of ARPA dollars that were invested, that helped to leap us forward. But at that scale, we would need that so many more times over to even start to make a dent for those extremely low income folks. When you get up to folks who actually have an income, it's a little bit higher, more into that 60 to 80% range. We only have less than half, 50% of the units, less than 50% of the units that we need purely from an affordable housing. So we just can't take our foot off the gas when it comes to every single affordable housing unit. And as many of you know, preservation needs to be part of the solution, because when we have so many units in the state of Nevada that were built on either a 15-year or a 30-year requirement to keep those housing units as affordable, we're losing as many units as we are building each year. And so getting ahead of that, it makes it very difficult to move the needle. So the bright spot there is back in 2017, the legislature wasn't talking about affordable housing. And it was only by the good work of many people on this call who supported an interim affordable housing study and the 8 bills that came out of that study that really got affordable housing on the radar again. And we just can't take it for granted. Prior to that, there was very little discussion going on in the Nevada legislature about affordable housing. So I just would encourage everybody to keep that effort up. I want to commend the Housing Coalition and all of its members. We got to figure out how to not let our differences on this topic get in the way of meaningful movement forward. So please stay, as a former senator, I'm telling you, stay on top of that advocacy. Don't assume that just because it's the hot topic now that it will continue to be the hot topic. Then the second piece I want to talk about is just the need for meaningful supportive housing. And so there is that challenge, of course, of affordability for everybody, but we have so many individuals who need either temporary supportive housing where they, in a rehabilitative model, where there is an opportunity for that individual to go from a place of not being well to a place of being much better and being able to, unfortunately, then have to go compete in that very expensive housing market that we have here in Nevada. But that rehabilitative model, I think we're making some good progress on. And I do think that is a bright spot. And I do think, Valerie, I think it would make a lot of sense for you to talk about the in lieu of services, because in terms of bright spots, it is one of our newest opportunities in our community. I don't think many people understand what in lieu of services means. I will just quickly say that a lot of things in Medicaid, when you think about Medicaid as a payer for healthcare services, they're mandates. If, you know, they're basically an entitlement. Like if you are a Medicaid member, you're entitled to that service if you need it. In lieu of services are this unique thing that it's not a mandate. There's a requirement that you're able to demonstrate that the services that you are providing would be more affordable than whatever the default service is. And that flexibility, that in lieu of services flexibility, allows for our Medicaid providers, the 4 managed care organizations who get these contracts and serve that population, to get more creative. And we have a new in lieu of services effort specifically around housing supports. And I want to be clear here that Medicaid cannot pay for housing, but they can pay for those supports around housing in this new in lieu of model. And just because we have a payer model where payers can pay for it doesn't mean that we have the service delivery model. And so if you are out there and you are a provider of supportive services, you need to tune into this conversation, be having conversations with your managed care organizations, because the build out right now of what those in lieu of services might look like, what the rates could be, what kinds of services they could be paying for that would really support somebody to maintain their housing, that's all being built right now. And so again, if you're a service, just because we have a payment system over here on the Medicaid side does not mean we have a service delivery system. That all needs to be built. And this is an opportunity that honestly we've been working on for a long time, because it required a waiver and it required all these steps with the federal government, et cetera. So for those of you who aren't in the healthcare world, I'm just going to say a decade of work has gone into getting to this point where we can do this thing. Let's not lose this opportunity. We need our providers to engage with our Medicaid managed care organizations, to engage with our housing organizations, to really understand the potential of this new in lieu of services program within the Medicaid contracts. And that's about as much as I can explain it, because I'm not a Medicaid person. I'm neither a healthcare provider nor a payer. I just know that it's a good opportunity. And so I do think, I just saw that Shana said in the chat, Valerie, I know you're moderating, but I think really explaining what that is would be helpful, because it is a bright spot of a place where we might be able to make some progress in the state of Nevada. So I just want to spend my last little bit on rehabilitative services are wonderful when a person has the capacity for rehabilitation. But in this healthcare housing conversation, we need to talk about people who also need habilitative services. And when I say habilitative services, what we're really talking about is individuals who are never going to achieve a level of stability that they will be able to live independently without support. And almost everything that we have built is a rehabilitative model. It assumes that there's a point in time when these individuals will be well, and we will be able to remove that support. If you think about what we do in the disability community, so if you think about the structures and supports that we've built for individuals who have a developmental disability or individuals who have a physical disability that qualify for some of those services, we just agree as a society upfront that that person is going to need that support over the continuum of their lifetime. But if you try to get habilitative services for somebody who is, say, seriously mentally ill and is going to need supportive housing for their entirety of their lifetime, the infrastructure, the funding sources, the policy that we need really does not exist for that behavioral health, mental health, substance use disorder. And if you go back to Nick's slides and you see the significant gaps between people who have behavioral health challenges, meaningful behavioral health challenges, specifically a serious mental illness. We have a model now that we still have behavioral health services that are capped. You can only receive so many visits. We have housing systems and supportive housing systems that when you are more stable and you're doing well, you no longer qualify for those services. And then when you lose those services, you destabilize. And so that you just end up in this cycle of I'm stable, I'm not stable, I'm stable, I'm not stable. So I would love to see us starting to have a conversation about how do we get the services available for people who have a serious mental illness to be comparable to the kinds of services we have in our community for somebody who has an intellectual disability or a physical disability. We say that serious mental illness is a disability, but then we have not built systems and structures around that to actually give folks the habilitative services that they're going to need over the course of a lifetime. And I'll just end this on a personal note. I have a dear friend whose daughter was diagnosed with a serious emotional disturbance when she was a child. She's now in her mid-20s. And I was on a walk with her the other day, and she's coming to the realization that her daughter will need supportive services for the rest of her life because of her behavioral health diagnosis and challenges, and is facing to the fact that it doesn't exist. And so there is a whole bigger conversation here, particularly when it comes to behavioral health and substance use disorder, of how do we up our game, and up it by a lot. And so then I will come back to advocacy matters. And so when your friends at the Nevada Housing Coalition or the other coalitions that you are engaged with send out that call of, we need your letters, we need your phone calls, we need you to engage on this policy solution, you have to engage. It's incredibly important that we at the systems and policy level move the needle in Nevada. And when you do engage, even though sometimes it feels like it doesn't make a difference, it does. And unfortunately, I think we're going to go into this next phase now, where many of the folks that we are talking about are quote unquote able-bodied individuals who were the beneficiaries of the Medicaid expansion through the Affordable Care Act, and some of the constraints that are coming down from the federal level now around work requirements and recertifications every 6 months means that a lot of the folks that we are trying to help with affordable and supportive housing may be at risk of losing their Medicaid coverage, which means then they lose access to all of these services. And so one of the other things that I think we're really going to need to work on together over the course of this next year is being ready to help people maintain their coverage. Because if they still qualify, but they just lose their coverage because they aren't filing the paperwork in a timely fashion, that will be devastating for them, but it will also undercut the stability of the healthcare services that we have available today. Because if you don't have enough clients, you can't keep your program open. So that's the piece I would like to put on the radar for everybody, is we all need to engage with the population that we're serving in our affordable housing developments, in our clinics, across the spectrum, to make sure that we do everything that we can to keep people covered who qualify for that coverage. So that's probably enough. I think I just rambled at you for a solid, I don't know how long. And I'm happy again to answer any questions, but I do think in lieu of services for housing supports is a place that we should talk more.
Yeah, thank you so much, Julia. I absolutely agree. And it looks like we have about 4 minutes, so I don't know if that'll be enough time for me to do it justice, but I think what I could say, because you already gave such a wonderful synopsis of some of the services that'll be available, is I would say a couple of things. One is that these won't necessarily be available for everybody who's experiencing housing insecurity, right? There are some additional condition criteria that have to be met in terms of eligibility. Also, because it's an in lieu of service benefit as opposed to a mandated benefit, not all of the MCOs have to offer it. So we are and want to do that because it's the right thing to do for lots and lots of reasons. But there are different implementation timelines because, as Julia mentioned, there are so many sort of different systems that have to be built out in order for this to be launched successfully. So in addition to what needs to happen internally within the MCOs to make sure that we're able to have the configuration set and the training materials ready and everything that is involved in the launch of this from an MCO perspective, there also needs to be the build out of the service provider network and what that looks like, and all of the training and answering all of the questions that you all might have. And so what is coming from all of the MCOs, and we're trying to work as collaboratively on the launch of this as we can, given that we all have different service areas, what's coming is going to be some very intensive training around basic things for folks who may not have billed Medicaid before, because a lot of the work now and a lot of the supports that will be billable will be provided potentially by organizations that may never have billed Medicaid before. And so we anticipate that you'll need and want the support to learn how to be contracted with Medicaid, how to contract with the MCOs, how to bill for the services. And we anticipate there will be a need for supports to actually help guide people through the billing process. We also anticipate that organizations will need help restructuring some of their sort of operational work and their budgeting to be receiving funding on a claims-based basis now, right? That isn't the same sort of cash flow cycle as maybe what nonprofits are used to. And so there's a lot more to come. So I would say, I don't know if there's an opportunity to have another session, a lunch and learn on this topic. I would definitely volunteer Anthem to be a part of that. But if not, just know that training is coming from your MCO partners in the future. There are a couple of questions in the chat. I'm not sure that we'll get to them, but we will definitely get you your answers in follow-up. And I will turn it back over to Amanda. Thank you so much.
Thank you, everyone. This was an amazing session, phenomenal information. We did not get to the 2 questions that I saw in the Q&A, but I will hand them over to our panelists, and we will actually send out the answers when we send out copies of slides and a link, if not tomorrow, by Friday. Love the idea of a follow-up lunch and learn one of these days. I will say, FYI, we will be more than likely having a breakout session on this topic at our conference. So if that is interesting to you, please stay tuned. We're hoping to get some of that information out in the next couple weeks. And lastly, please join us for our August Lunch and Learn. We're going to be welcoming the Nevada Housing Division, who will be speaking on AB 540, the Nevada Attainable Housing Act. So thank you, everyone. Have a great afternoon, and we will see you next month.